Good afternoon. Welcome to MTBC Audit Services E&M Auditing. My name is Andy Tolep. I'm a certified coder with both AHIMA and AAPC. MTBC was founded in 1999 and we currently serve 45 unique medical specialties in 39 states. We have over 1,000 employees with 24/7 operations. We have a 95% claims first-time pass rate, meaning our rejection rate is under 5%. We're ranked among Deloitte Technology's Fast 500, and we're a SureScript certified solutions provider. Today's topics of discussion will be the following. A, what is E&M auditing? B, what are RACs and what are the RAC audits? When are RACs coming? C, the CMS and New Jersey benchmarks for family medicine. At a later date, you can request the benchmarks for your state and specialty. D, how can MTBC help make sure my practice is documenting appropriately to code a certain E&M level? And finally, E, the components of a physician visit we will discuss briefly. They are as follows: history, exam, medical decision-making, and time. So what is E&M auditing? E&M auditing ensures the documentation of a patient history, exam, and medical decision-making match the E&M code selected. An audit process can be done for many types of visits, including office visits, hospital visits, and ER consultations. What is the difference between internal and external auditing? Internal auditing is when a physician practice audits their own E&M coding, either by a staff member or through a third party, such as MTBC. External auditing is an outside organization, such as a RAC, MAC, or commercial insurance, auditing and practices E&M coding. AHIMA recommends internal audits are done quarterly, whereas external audits can happen as much as annually. What providers are at risk of an external E&M audit? Individual physicians or providers who frequently bill the more expensive and complex E&M codes, including 99214 and 99215, are at the highest risk for an external audit. OIG found that among physicians who consistently billed higher level E&M codes, 19.8% were internists, 12.2% were family physicians, and almost 10% were in emergency medicine. So as you can see, the focus will be on primary care doctors, which is a good portion of MTBC's client base. Although many EHR systems can assist providers in assigning codes for E&M services, the OIG actually found that most Medicare physicians manually assign E&M codes. And we here at MTBC have also found that many of our clients are still manually assigning E&M codes, even though the MTBC EHR can help docs in choosing a E&M code. What is the difference between undercoding and overcoding? Undercoding is providers who tend to downcode their services. In other words, docs who code a higher percentage of level 2s and 3s compared to their peers. Undercoders may be losing potential revenues, so it's a good idea to do an audit to make sure you're not actually undercoding. Overcoders would be providers who tend to upcode their services, docs who code a higher percentage of level 4s and 5s compared to their peers. Overcoders would want to conduct an audit to make sure the documentation truly matches their higher usage of level 4 and 5 codes. But the key is, if it's not documented, you can't code it. You have to code based on the actual medical documentation. What are RAC audits? The RACs are the recovery audit contractors contracted by CMS that identify and recover improper Medicare payments paid to providers under fee-for-service Medicare plans. They're responsible for detecting and ultimately correcting past improper payments, so that CMS and MACs can implement actions preventing future improper payments. The RAC program in the United States is divided into 4 regions: Performance Recovery, Region A, which represents the Northeast; CGI Group, which is Region B, representing Michigan, Indiana, and Minnesota. The biggest region will be Connolly Incorporated, which is 17 states in the South, including Texas. And finally, Region D, Health Data Insights, which is the West and Midwest. When are the RACs coming after providers? Well, CMS's RAC in Region C, Connolly, has been instructed to commence audits on high-level E&M codes already. They will focus on physicians' use of higher level E&M codes, including 99214 and 215. Commonly is reviewing records to ensure that higher E&M levels justified during an initial office visit are not duplicated in subsequent repeat or routine visits, or where lower E&M levels are expected. RACs in the other 3 regions of the country will follow suit with similar audits in the near future. Health Data Insights RAC Region D publishes a list of audit targets by provider type, and as you can see, I provided the source right here. Now we're going to discuss CMS and New Jersey benchmarks for family medicine. We're going to break this down by type of visit: new office visits, established office visits, initial hospital care, and subsequent hospital care. First, new office visits. As you can see, the majority of visits are 203s and 204s, about 75% of the country, whereas about 79% of the state. As you can notice, in New Jersey, providers tend to code higher on the new patient side. Over 43% are at 4 and 5, we're 37% of the nation. So New Jersey docs tend to code a little bit higher for new office visits. Whereas established office visits, it's pretty similar within the country and the state. About 90% are coding either 1.3s or 1.4s, with about half at 1.3 and about 40% at 1.4s. Initial hospital care visits, you have almost 96% in New Jersey are coding at the 2.2 or 2.3 level. If you notice, the 2.3s are higher in New Jersey than in the country. Country's at 51%, whereas in New Jersey, 56%. Subsequent hospital care. Almost over 90% of the state are coding at the 3.2 or 3.3 level, whereas almost 83% are coding at the national level. So New Jersey tends to code higher as well. Particularly New Jersey tends to code significantly more 2.3.2s than the nation, whereas significantly less 2.3.1s than the nation. How can MTBC help make sure that your practice is documenting appropriately? Well, at no cost to you, we can run your practices and providers' E&M utilization and compare them to the national and state standards. Our auditing services group can then audit 20 random charts, office and/or hospital, your choice, from the last 6 months of data to ensure that your E&M codes match the medical documentation in the medical record. If you're charting within the MTBC EMR, MTBC can pull the data needed for your audit. And that includes if you're doing transcription within the MTBC EMR. If you're charting in another EMR or on paper charts, I hope not, MTBC can work with your practice manager to pull the necessary records for an E&M audit. And what are the components of physician note? There's 3 key components: the history, which would be comprised of the chief complaint, the history of present illness, or the HPI, the review of systems, and the past medical, family, and social history. And there are 2 guidelines, 1995 and 97, that CMS came out with. 97 guidelines allow for you to report on the status of chronic conditions for the HPI. The exam, the difference is 95 guidelines are very generic, whereas 97 guidelines are specific based on bulleted items. And finally, the medical decision making, which is comprised of the number of diagnoses and problems that a patient has on that visit, the data to be reviewed and ordered, and the risk involved in the medical decision making. A lot more detail will be gone into if you are to purchase an audit from MTBC. Now, time can only be used to calculate a code if the provider documents that more than 50% of a visit was counseling to the patient and or patient's family. So most of the time you're going to use the 3 main components: history, exam, medical decision making. I want to thank you for your time. If you have any questions or comments, you can contact us at info@mtbc.com. Thank you and happy auditing.